Today, our topic of discussion is iron mineral. As you already know, there is a regular class of minerals. Okay? So, mineral is what? It is an important constituent of our diet which is required for proper growth of the body. And on the basis of quantity, it is divided as major minerals and micro minerals and macro minerals on the basis of requirement of quantity. So we separate out this on the basis of quantity: calcium, iron, copper on the one side and zinc, iodine, fluoride on the other side. Okay? Now it is a good method to take the attendance. The strength of the class is increased. जब पहले कहते थे कि सब लोगों को आना चाहिए क्लास में तो कोई नहीं आता था. अभी जब अंगूठा टेक हो गए तो सब लोग आ रहे हैं. Okay, now today we start the main important constituents of our diet which we take regularly, dietary form, and it is the most important functions in the body, that is called iron. Okay, so the total amount of iron which is present, if we see the distributions of the iron in the body, is 3.5 to 4.5 gram. 3.5 to 4.5 gram. Okay. As you already know, iron is a very important constituent which is generally present in the heme constituents. Okay. And large amount, approximately 70% of the iron is generally present in the form of RBCs. If you see the structure of RBC, there is a hemoglobin protein which is a tetrahydrofolate, which is a combination of iron. Okay. The central carbon atom which is present in the hemoglobin. So mostly the major portion of the iron is generally present in the body in the form of RBCs. Okay. They are blood and blood forming organs, larger reservoir of the iron in the body. Okay. Generally the blood is mostly, iron is mostly reserved in the liver and spleen and bone marrow as a reserve form. Okay, so that's why it says this point. But small amount of iron are present in nearly every tissues. So these are the important iron containing compounds: hemoglobin, myoglobin, ferritin, hemosiderin, transferrin, cytochrome, iron containing enzymes. Which one is iron containing enzymes? Which one is iron containing enzymes? Catalase, cytochrome C oxidase, peroxidase. So all are important iron containing compounds: hemoglobin, myoglobin, ferritin, hemosiderin, transferrin, cytochrome. These all are important iron containing compounds. Okay. If we see the physiologically active form of enzymes, it is myoglobin and heme, catalase and peroxidase. About 80% physiologically active form of iron is present in the form of hemoglobin and myoglobin. Okay. Now these are the factors which influence absorption of iron: reduced form of iron, ascorbic acid, interfering substances, and other materials. Okay. So firstly, you understand the distribution of the iron is generally present. Distribution of iron is generally present in the form of myoglobin and in the form of storage form, that is called ferritin. Ferritin is what? It is a storage form of iron which is generally stored in liver spleen, bone marrow. Okay, three important organs of the body. And non-heme iron containing enzymes are non-heme iron containing enzymes are xanthine oxidase, cytochrome C oxidase. Okay. Now generally you will tell me in which form iron is absorbed. It is reduced form? Yes. Generally generally iron is we take in the diet in the form of ferric, that is Fe3 positive, and it is reduced into ferrous form and is being absorbed. Okay, so these are the factors which influencing absorption of iron. That means reduced form of iron. Iron are generally absorbed in the form of ferrous Fe2 positive, and this is the process by which ferric are converted into ferrous form. Okay. So for this factor, if we see the one factor that iron is maximally absorbed in the form of ferrous form, and there are several factors which can reduce this iron, like vitamin C. Okay. These all are interfering substances in other forms. Now we teach some of the separately all the components of the iron. Understand? We understand all the component of the iron. That is ferritin. It is a storage form of iron that are mainly present in liver, spleen, and bone marrow. And also some of the amounts are present in brain, kidney, intestine, and placenta. As we already know, iron is a very important constituent for the human being. It is largely required in the females because due to the repeated pregnancies, due to the irregular menstruation cycles, there is loss of iron is occur in the form of blood. Okay, so that's why it is important to understand the role of the iron. Okay, and if you see due to this iron, there are iron deficiency anemia is largely spread in all over developing countries. Okay, so that is important. It is one of the storage form of the iron. The protein portion is known as apoferritin. Apoferritin combined with iron to form ferritin. So ultimately, what is that is important? Apoferritin. Apoferritin portion is very important for the storage of iron, because if the apoferritin is not present in the liver, we see that how apoferritin plays a role for the absorption of iron. Understand? Lastly, the iron is generally converted into ferrous form, ferric form, ferrous form, ferric form, and after that in the blood it is combined with apoferritin, and finally it converted into ferritin for the storage form. Means these are the component of the iron, ferritin. If somebody is telling what is ferritin, you will say it is a storage form of iron which is generally present in the large number of the body like liver, spleen, bone marrow, brain, kidney, intestine, and placenta. Now iron containing enzymes, there are several are metalloenzymes. You already discussed in the enzymes chapter that most of the enzymes are iron containing enzymes. These are, in some cases, iron form an integral part of this enzyme molecules. In other, presence of iron is required for catalytic activity of the enzymes. Means it is iron depending enzymes. The examples are catalase, peroxidase, aconitase, succinate dehydrogenase, and xanthine oxidase. So mostly the question asked in your exam, it is a long answer question. Student, it is asked in long answer question way. Okay, what is iron? Write about the metabolism of iron. Why iron is important in the metabolism? Okay, so all of you write it. Example of such enzymes are catalase, peroxidase, aconitase, succinate dehydrogenase, xanthine oxidase. These all are what? Metalloenzymes. It is especially depend on iron for their functional activity. Either the iron is present inside their structure or its catalytic activity depend upon the iron. Before understand the absorption of iron, we have to understand that where this, in which portion of the stomach this iron is absorbed. It is absorbed in upper duodenum part of the stomach. 5 to percent dietary iron absorbed from GIT. Okay, 5 to 10% iron is absorbed from GIT, and dietary iron is generally exit in ferric form and absorbed in gut in as ferrous form. So ultimately what I say that iron is generally absorbed in the form of ferrous state, not in ferric state. And iron are generally present in the diet, in the dietary source in the form of ferric form. Which one is the dietary source of the iron? From the last, Rahul, which one is the dietary source of the iron? क्या? Mango? Basically, we divide the dietary source of the iron in three ways. Like there is the richest source of iron is red meat, okay, because it contains generally liver, and the other sources if we eat, the appropriate amount of iron is present, richest source. And if generally we take here jaggery is a local what? Good. That appropriate amount source of iron. Okay. And green leafy vegetables like spinach. So all these are important. All these are important dietary sources. Okay. So in these dietary sources, iron are present in ferric form. Okay. After then, it comes to the GIT through the internal absorption in the duodenum part of the stomach, and there is release of what? Hydrochloric acid, that is called gastric HCl, which is combined with dietary sources, and it remove out the iron in ferric form, and by enzymatic activity it is converted into ferrous forms. Okay. Now we understand there are some of the factors we are just understand the proper absorption of iron. Okay. That is the dietary iron, that is mostly non-heme iron, bound to protein. non-heme iron bound to protein. We take the iron in the dietary form, which is mostly non-heme portions. Okay. Then here we take, and here these iron are generally present in which form? Ferric form. Okay. And it is absorbed in the stomach and duodenal part of the stomach, and in the stomach it's combined with gastric HCl, which is generally present in our digestive system. And it, due to the combination of this HCl, what happens? There is a removal of iron particle from this northbound heme part. So iron is generally present in which form? It is present in Fe3 positive, that is we called as free non-heme iron. What is called? Free non-heme iron. Before writing in your copy, you have to understand this part. We take the iron in the dietary food, which is the non-heme part, which is bound with the protein or not. Okay, by taking in the diet, it's going to the stomach where it's combined with HCl and it's make three non-heme iron molecules. We use it HCl extract with the iron in the stomach. Now, this is what this is, ferric state. Now, the next step, what happens? The first process, their reaction is to be called reduction. Okay? Their reduction process is occur, which is mainly proceed by vitamin C, amino acid cysteine, and glutathione. What is glutathione? What is glutathione? Anyone can tell me? Glutathiones are the important biologically active peptides which reduce the activity of reactive oxygen species. Okay, reactive nitrogen species. So it acts as an antioxidant for the body. Glutathione. Okay, what the glutathione do here? It converts the iron form into ferric form into ferrous form. That is Fe2 positive. It converts. Okay. Now in the next step, we call it, this is the first step. Now in the next step, what is here? It is combined with intestinal mucosal cell, intestinal mucosal membrane. So now this ferric form, this is ferrous form of iron, enter in the intestine. So by combination of intestinal mucosal cell by energy dependent transport system. By energy dependent transport system, here is a co-transporter or transporter is present. We call this transporter as DMT, divalent metal transporter. We call this as DMT1. What is the meaning of DMT1? Divalent metal transporter 1. Divalent metal transporter 1. This is energy dependent transporter because you already know there is the co-transporter is present for transport of this parasite. Okay, and it is present in intestinal mucosal cell. Intestinal mucosal cells are here. It is present in generally virus form. Now it enters in the mucosal cell in the form of virus form. Now also this, all of you understand, we take the iron in the form of diet and it is excreted out from the dietary product by the activity of HCl, by the activity of gastric HCl. Okay, and it is excreted out in the form of ferric form. After then, it's combined doing the first reaction we called as reductions, and it is reduction is proceeded by the vitamin C, cysteine, and glutathione, and it is converted into a ferrous forms. Then it's combined with the DMT. DMT is what? Dimetal transporter 1, that is a co-transporter which is generally present in the membrane, and it is energy dependent process. It enter in the mucosal cells in the form of ferrous. Okay. Now after then, I see step by step process. Okay. By the enzyme activity, these are clearly written. It is present as Fe2 positive by the enzyme activity of ferrooxidase. Which enzyme? Ferrooxidase. It is combined. It is now converted as, means here is oxidation is occur in the reduction form. Iron is reduced into the ferrous, and after the activity of ferrooxidase, it is converted into again ferric form. Okay. All these are processes occurring at mucosal cell, intestinal mucosal cell. So now here with this ferric form, there is a one protein. Here is a one protein is combined with this ferric form and makes it transferable. That is apoferritin. And it makes the iron ferritin. Ferritin. Now, this is a step-by-step process. Okay, this ferritin is now containing Fe3 positive ion, and there is a removal of effort, putting in the next step, and in this position, in this ferric form, again I have on it, we called as ferroreductase. Ferroreductase, and it converts this molecule as again in ferrous form. Now this ferrous form enters in the blood by vasolateral transport membrane, by the completion of vasolateral transport membrane. Basolateral transport membrane. And it comes in the blood in the form of ferrous state, Fe2 positive. Okay? Now, after this, there is no confusion regarding that. We take and it is finally comes in intestinal mucosal cells in ferrous form. Then, with the activity of ferroxidase, it is converted into ferric form, and this ferric form converted into ferritin by the combination of apoferritin. It is present in the mucosal cell. Okay, understand? If these are the transformer reactions, ferritin is what? It is storage form तो है ही. So here storage form is important. So apoferritin is very important protein. Apoferritin is very important protein. Why it is important? Because if apoferritin is present, most of the iron is absorbed. If apoferritin is completely saturated, iron is not absorbed. Understand? So these are basically explained by the scientist Grading, and this theory is called mucosal block theory. What is called? Mucosal block theory. Now from this step, now you see from this step, it is entered in the blood. It is entered in the blood, and this ferric form again converted into ferrous form by the activity of ceruloplasmin. By the activity of ceruloplasmin. What is ceruloplasmin? Ceruloplasmin. You already know ceruloplasmin is what? It is a copper containing enzyme. Copper containing enzyme. Generally it is a blue color, but in the human being it is as yellow color substances. That's why we call as cytoplasmin, or generally we call as here ferroxidase. This is second name of this cytoplasmin. Ferroxidase. This converted this iron ferrous form into ferric form in the blood. Now in the next step, this can combine with apotransferrin to make this iron transferrin. Transferrin is again storage form of the iron, and we call as siderophilin. Siderophilin. Siderophilin, and this transferrin siderophilin is reach out to several organs like liver, and spleen for storage, and bone marrow RBC production in the bone marrow. So iron is important. And lastly, in the muscles and other tissue like brain, muscle and other tissues. Okay. So students, muscles and other tissues. So now what is basically in the absorption? If we see the absorption, there are basically a 5 to 6 step. In the first step, we take the iron in the dietary form, which is non-heme iron containing compounds. First thing. Second thing, it is combined with the gastric HCl and there is removal of iron molecule in the ferric form. After then, it is react with vitamin C, glutathione, cysteine, and it convert this ferric form into the ferrous form. In the next step, these ferrous forms going to the co-transporter. We call this transporter as divalent metal transporter 1, which is present in intestinal mucosal membrane. This is energy dependent process. These ferrous forms is now comes in the mucosal cell in the form of ferrous form. Okay, these ferrous form is again react by the activity of ferrooxidase enzyme. It is converted into ferric form. When this ferric form is again combined with the protein we called as apotransferrin protein, its form ferritin. Its form ferritin. Ferritin is again a storage form. The 15% of the iron distribution are generally present in ferritin and hemosiderin form. Okay. After then, in the next step, this ferritin is again combined with ferroreductase enzyme. It converts this molecule as Fe2 positive. There is a removal of apoferritin, and this ferritin is converted as this iron molecule is separate out in the form of ferric, and again it is combined with ferroreductase enzyme. It is formed Fe2 positive. And now through the basolateral membrane, it's going to the blood in the reduced form, ferrous form. This is Fe2 positive. In the blood, there is copper containing enzyme is depend, because that's why copper and iron both are reciprocal for the absorption process. Okay, ceruloplasmin. These ceruloplasmin act on ferric molecules and it convert again ferrous form into ferric form. And this ferric form again combined with the apotransferrin protein and ultimately make transferrin protein, we call that cytosine, and these transferrin protein going to the several tissues for the storage. So ultimately this is called as absorption and transport of the iron. What we call absorption and transport of the iron. Now there are some most of other factors. They are the factors which can increase or decrease the absorption of iron. Okay, the first one is HCl. HCl generally increase the gastric HCl. Okay, increase the absorption of iron. Second factor is vitamin C and glutathione, increase the absorption of iron. समझ में आ रहा है कि नहीं आ रहा? पहला है आपका gastric HCl that increase the absorption of iron. First thing, in the case of E. coli hydria, what do you understand by E. coli hydria? Yes, there is less absorption of the iron. Okay, so there is no secretion of the HCl. Vitamin C, cysteine and other reducing substance promote the absorption of iron by the process of reductions. Third point, HCl favor promotions, alcohol ultimately favor promotion for the absorption of iron. Okay, and acidic pH and acidic food ultimately increase the absorption of iron. or which one is decrease the absorption of iron? Yes. The ultimately taking of tea and coffee. Why? Because it makes iron tennate complex. It combined with the protein which is present in the ferrous form. It is combined with the tea and form iron tennate complex, which is precipitate the iron and not absorb. Okay. Second one is oxalate decrease the absorption of iron. High fiber diet decrease the absorption of iron. Deficiency of copper decrease the absorption of iron. You already know why. Because there is ceruloplasmin is utilized for the absorption. And if there is no copper, no ceruloplasmin is occur, less absorption of iron is occur. Phytanic acid, which is mainly inositol hexophosphate, decrease the iron by making iron phytanic acid complex. And lastly, gastrectomies, surgical removal of, yes, surgical removal of this process ultimately decrease the absorption of iron. Now we see what is mucosal block theory. What is mucosal block theory? You see, duodenum and jejunum are the site for absorption iron atom metabolism, and hemostasis is regulated at the level of absorption. When iron stored in the body are depleted, absorption is enhanced. When more enough quantity of iron is stored, absorption is decreased. This is mucosal block theory. So ultimately, mucosal block theory explains the regulation of the absorption of the iron. Understand? It explains the regulation of the iron. How it is? It is generally said that if there be more iron is absorbed, more iron is stored, ultimately there is less absorption is takes place. It is explained mainly by mucosal block theory. So you will see only ferrous form of iron is absorbed. Ferric iron reduced to ferrous iron by ferric reductase enzymes. Ferrous iron is the intestinal lumen binds with a mucosal cell protein called dimetal transporter DMLT1. Dimetal transporter 1. Inside mucosal cell, iron is oxidized to ferric state and complex with apoprotein to form ferritin. So these all are the processes we already see and discuss here. That is combined with some apoprotein molecules. Okay. So in the generally what happens in the case of anemia, the iron is further absorbed into the blood and transferrin is saturated with iron accumulates in the mucosal cell, and this cell is this when iron absorption is reduced, this is basic of ultimately what is mucosal cell says? Mucosal cell says there is a saturation of this apoprotein. The saturation completely combination of this apoprotein molecule with the iron is regulates the absorption of the iron. If apoprotein is not present, iron is not absorbed. If apoprotein is present, iron is absorbed. How the apoprotein is not present? If iron is stored in the maximum quantity. ठीक है, जब आपका आयरन मैक्सिमम क्वांटिटी में एब्जॉर्ब हो जाएगा तो वहां पे एपोप्रोटीन देयर इज नो फॉर्मेशन ऑफ कॉम्बिनेशन कॉम्प्लेक्स. Okay, these all are regulated by homeostasis process. Okay, this is ultimately a homeostasis process. So these all are explained by mucosal block theory. We called as mucosal block theory. Transport of ferric in the plasma, storage of iron. Iron is stored in the liver, spleen and bone marrow in the form of ferritin. In the mucosal cell, ferritin is a temporary storage form of iron. Why it is called temporary? Because Because apoferritin is removed out in the next step, and this ferritin, the ferrous form of iron, is converted into ferric form. Hemosiderin is another storage protein which can hold about 35% of iron by weight. Hemosiderin accumulates in the body when supply of iron is excess amount. Function you already know: transport of oxygen, oxidative reaction, tissue respiration. Now that is important, the RDA. Now up to this we complete the absorption, refusal wave theory, and the RDA. RDA is what? Recommended dietary allowances. Recommended dietary allowances for infants 6 to 10 milligram per day, children 10 milligram per day, adults 12 milligram per day, adults male 10 milligram per day, lactating women, premenopausal women 50 milligram per day, pregnant women 30 milligram per day. Because you already know it is required in different fractions. It is required in the placenta, it is required for the fetus development, okay, and it is generally the values also change. The women which have irregular menopause cycle require up to 20 to 30 milligram of iron per day. Okay, so in the developing country in India, and there are the prevalence of iron deficiency anemia. Iron deficiency anemia is more. Why? Because there is repeated pregnancies, less of iron in the diet, okay, less of knowledge. All these are the cause of iron deficiency anemia. Now disease state: nutritional deficiency of anemia, hookworm infection, repeated pregnancies, chronic blood loss, nephrosis, lack of absorption, lead poisoning, steatoria, celiac disease, gastrectomy. So all are ultimately what? Ultimately body needs iron regularly demands, because you know that iron is the main source of RBCs. RBC is continuous degradation process. It forms in the bone marrow, it degraded. So ultimately there is a degradation of the iron, and iron is not generally excreted out. For the iron, it is said that it is whole component is absorbed in the body. Some of the part is excreted out in the form of in the fecal material, okay, and also some of the amounts in the urine, and major portion is lost during blood loss. Now iron toxicity. What is iron toxicity? More than 50 milligram of iron take orally causes nausea, diarrhea, and abdominal pain. And this for the students for that ultimately during the pregnancy, when the consultant suggests to take more iron in the diet during the pregnancy, the most of the women complain about the heaviness of the liver, heaviness of the stomach. Why? Because it is not metabolized. It is causes nausea, diarrhea, abdominal cramp. Okay, it causes constipation. So ultimately, this is called iron toxicity. Hemosiderosis. What? Iron excess is called hemosiderosis. Excessive iron deposit as ferritin and hemosiderin. It is commonly observed in subjects receiving repeated blood transfusion over the year, patient of hemolytic anemia and hemophilia. It is what? It is generally observed in the subject receiving repeated blood transfusion over the year, patient of hemolytic anemia and hemophilia. Lastly, Bantu siderosis. What is Bantu siderosis? It is an epidemic cause. You have to understand the area, Bantu tribes area of Africa generally having this iron toxicity because their staple diet is corn. If they are regularly take a single type of diet, they ultimately make more iron in the body in the form of ferritin and hemosiderin, and it ultimately cause iron toxicity. Now, hemochromatosis, when total body iron is higher than 20 to 30 gram iron is directly deposited in the tissues, okay, and When iron deposit under the skin cause yellow-brown discoloration, it is called hemochromatosis. Ultimately, these are the terms referred for the deposition of the iron. If more iron is deposited in the skin, in the organ, liver, spleen, and pancreas, it ultimately changes the color of the skin, which is called yellow-brown discoloration. Okay. It is also called bronze diabetes. It is also called bronze diabetes. It changes the color of the skin. Hemochromatosis. Okay. It is also called bronze diabetes. Now, hematomegaly, cardiomegaly, congestive heart failure, hypogonadism, diabetes mellitus, and bronze-colored pigmentation of the skin are usually clinical abnormalities. The condition is also bronze diabetes. It is also known as bronze diabetes. Treatment: phlebotomy and iron chelating agents like desferrioxames are used to remove excessive iron. So all are the clinical condition which is associated with iron toxicity. And finally, there is being a large project to understand iron deficiency anemia. Most of the research are generally proceed in iron deficiency anemia. Okay, so that's why iron is a very important mineral. I think all of you understand today the distribution of the iron. That is 70% of the iron are distributed in the form of heme containing irons. It is heme containing enzymes or heme containing myoglobin, hemoglobin molecules. These are the distribution. Absorption you already know. These are the factors which can increases or decreases the absorption. Mucosal bulk theory is what? It shows the regulation of the iron by the presence of aphotransparent proteins. Okay. Hypedin, some of the protein which is released in the liver, which is mentioned some of the books but is not mentioned regularly. Aphotransferrin is called hypedin and hepcidin. Yes, hepcidin is a protein which is released in the liver, which is increase the absorption. Ultimately, what I say some of the factors are important for the absorption of iron. This is called aphotransferrin. It is completely saturated, then no iron is absorbed. So इसका मतलब क्या है? जब आयरन आपका एक्सेस में एब्जॉर्ब करेगा तो वहां पे एपोट्रांसफर प्रोटीन आपका खत्म हो जाएगा, तो वो आपको आयरन को एब्जॉर्ब नहीं होने देगा. अल्टीमेटली इट रेगुलेट द एब्जॉर्प्शन ऑफ आयरन. ओके, if there is more iron, we take more iron, it is called iron toxicity. If we take less iron, it is called less toxicity. Generally, bronze diabetes is shown in liver disease, especially in liver cirrhosis. The color of the skin becomes changed. Generally, you see the subject of liver cirrhosis, there is the color of the skin become changed. Okay, so these all are about the iron. You go to and take a one reading, all of you understand. Okay, thank you.
Okay, today we are going to discuss about the radius, right? So as you know, radius is the bone of the which side? It is present on the lateral side. So for knowing the anatomy of the radius, you have, it's very essential to know the side examination. Okay, so the radius has got how many parts? The upper end, shaft and the lower end, just like the other long bone, right? But in the upper end, it has got one rounded surface. Okay, superior surface. It is also known as head of the radius. So it will articulate with which structure? Superior surface. Superior surface of radius will articulate with it will articulate with capitulum of humerus. Okay. So this is the first joint. So that is known as radiohumeral joint. Okay. It is also a component of the elbow joint. Okay. So rather than that, in the superior part, you will also get another joint. So suppose this is a radius. Okay. So you will get another joint over here. So that is known as Superior radioulnar joint. Okay, so at the upper surface it has got two joints. One is this one, rounded head, right? It is joint along with humerus. So that is radiohumeral joint, or it's a part of elbow joint. Is it which type of joint it is? Elbow joint is a which type of joint? Huh? It is a type of hinge joint, right? But the superior radioulnar joint. Okay, so you have to know this is a head and this is a neck. So here you will get one annular ligament. Okay, annular ligament, which is not a complete ligament. Okay, so it will articulate along with ulna. So it is known as superior radioulnar joint. Okay, so it is a which type of joint it is? Do you know? Superior radioulnar joint. So I told supination pronation is taking place in which joint? Radioulnar joint, right? Superior and inferior radioulnar joint. So this is a superior radioulnar joint. Remember, it is a type of pivot joint. Okay. So pivot joint means there would be one axis, another would be ring, right? So annular ligament is here. It is ring, acting as a ring, but this radius is acting as a axis. Okay. So here we could see the ring is fixed. Okay, ring is fixed whereas the axis is moving. Okay, so could you find another example of pivot joint? Where else you will get pivot joint? बोलो अदिति बोलो. Yeah, head neck में कहाँ पर होता है? बोलो. Atlas and axis. Here we could see what? The odontoid process of axis is fixed, but the ring is rotating. Okay, that is the atlas. Atlas it is rotating. So it is another example of pivot joint. Okay, so one we are getting the superior radioulnar joint. Again at the below we will get another joint that is known as inferior radioulnar joint. So it is a type of, again it is a type of pivot joint. Okay, but in the middle, how to identify the interosseous border? Okay, so this is the upper end. So in upper end, what are the things you could see? First one is this is the head, right? And this is the neck. Just beside on the medial surface, we are having one elevation. This is also known as radial tuberosity. This is known as radial tuberosity. Okay, but in the shaft has got how many bordered surfaces? It has got 3 bordered and 3 surfaces. So which one is the anterior border here? Which one is the anterior border? So this one is the anterior border. Okay. Then this is the medial border and this is the lateral border. So it has got 3 border. How many surfaces? 3 surfaces. First one is, this one is the anterior surface, this one is the medial surface, and this is the posterior surface. Okay, so we are having 3 border and 3 surface. Now how to identify the medial surface? See, the medial surface would be sharp. Why? Because of the attachment of the intraosseous membrane. So this is also known as intraosseous border. Okay, so rather than that, in the lower end we are having one projection on the lateral side. This is also known as styloid process. So styloid process would be always on the lateral side. Okay, and another one is listed tubercle. Listed tubercle would be always present on the posterior surface. Lower end at the posterior surface. So how many things we have to see? First one is head, facing upwards, rounded head, radial tuberosity towards the medial side, and this sharp interosseous border, it would be facing medially. Okay, and this styloid process projected part, it would be present on laterally, and posteriorly there is presence of listed tubercle. Okay, at the lower end. So these are the features. By that way you could determine the side. So which side of radius it is? Left or right? So I told styloid process would be present laterally, right? So it would be present laterally. See the radial tuberosity. It would be medially, intraosseous border on the medial side, and this is the listed tubercle that will be facing posteriorly. Okay, so it is you have to also see the styloid process. The projected part would be always facing laterally. Okay, so which side of radius it is? Right radius. Okay, so by that way you could determine this is the side. Okay. Shurudip, slide. So this is the general features. Okay. So it is the lateral bone of the forearm and it is homologous to the tibia of the leg. Okay, not fibula. Fibula क्या है? Leg में lateral compartment में है, but this is reverse. Okay. So which bone? Don't say it is with fibula. Okay, Allah is with fibula, just reverse. Okay. Then the next one. So see, by that way, these are the anatomical position. You could write it down. Okay, so first one is head would be facing superiorly, okay, and radial tuberosity and intraosseous border, it would be found on medial side, okay, and styloid process that would be also present on laterally, and listed tubercle. Listed tubercle is very important, this one. Okay, this tubercle is also known as listed tubercle. It would be always present on posterior side. Okay, so these are the few features. By that way, you could determine the side. Okay. So these are the features. Okay. So where is the position of annular ligament? Annular ligament is very important. See on the neck, it would be present just above the radial tuberosity and between the head. Okay. And this side, head would be articulating superiorly with capitulum. Have you seen the capitulum in humerus? Okay, so it would be facing capitulum. Then which part would be articulating to the superior side? You know superior radioulnar joint. So I am asking which part of the ulna will articulate with radius? Which part of the ulna will articulate to form the superior radioulnar joint?
Radial notch.
It is radial notch of ulna. Okay, it is radial notch of ulna. And inferior notch? So styloid process would be facing laterally. So this is the intraosseous border. So here there will be inferior radioulnar joint. So head of the ulna. I told head of the ulna is reverse, right? It is facing downwards. So head of the ulna will articulate with the lower end of the radius. Okay. So next slide. So these are the three things. These are the part, head, neck, and the tuberosity. Next one. Okay. Next one. Okay. So right now head is shaped like a disc. You see, right? And covered with hyaline cartilage. Only this part is covered with hyaline cartilage, not all. Okay. Only superior part. So it articulates superiorly with capitulum, and circumference of the head forms superior radioulnar joint, and rest are surrounded by the annular ligament. Okay. So where you could get the annular ligament only at the neck. Okay. So these are the picture. Next slides. So what is the neck? Okay. Which structure is articulated with the neck? Okay, it is a constricted part just below the neck, and synovial membranes separate the neck from the annular ligament. So which structure is present between the annular ligament and this hyaline cartilage? That is synovial membrane. Okay, so there is one term again. Which one is the extra synovial but intracapsular? Okay, extra synovial, intracapsular. Okay, and quadrate ligament. Quadrate ligament. Here it is attached to the head, neck, and both head and neck both will rotate within the annular ligament and as their freeform capsule. It's very important. Okay, but here it is just the reverse. Okay, it is intrasynovial but extracapsular. Okay, intrasynovial but extracapsular. Both head and neck of the radius. Okay. In the next slide. radial tuberosity. You know, in the radial tuberosity, which thing is attached?
Biceps tendon.
Inserted. Which thing is inserted? That is tendon of which head?
Which knee?
Both. Okay. Origin is different, but they are forming a together one single belly. Okay. That will insert where? To the radial tuberosity. Okay. And from that you are having one medial aponeurosis, that is known as bicipital aponeurosis. Okay. And remember, there is one bursa. Okay. Between the tendon of biceps and radial tuberosity, there is definitely one bursa is there. Okay. Then the next one. So SAP has got three borders: anterior, posterior, and medial. So as I told you, this one is the anterior border. Most sharp border is the medial border, and here at the posterior surface, where the styloid process ends. From there, if you go above, you are having the posterior border. Okay, and three surfaces: anterior, posterior, and the lateral surface. So why the lateral surface of radius is so much important? Because medial side is interosseous membrane, right? So all the muscle will take origin from the lateral surface. Okay? So lateral surface and also from the anterior surface. Okay? Next one. So anterior border, it will extend from the radial tuberosity up to the styloid process of the radius. So which thing will take origin? Anterior oblique line gives half of the radial side, that is flexor digitorum superficialis. So flexor digitorum superficialis is which compartment muscle? Front of forearm definitely, or superficial or deep? So it is superficial. So is it crossing the flexor retinaculum or not?
Superficial.
Is it a content of flexor retinaculum?
No.
So tell me which are the content? Extension the canal, flexor retinaculum. Flexor? Deep compartment muscle, name them. Pronator border is the superficial muscle. Okay, anything? What are the three muscles of the flexor compartment, deep surface? One is flexor digitorum profundus, another one is pronator quadratus, then flexor pollicis longus, then three only. There are only three muscles in the deep compartment. Okay, and remaining are present on the superficial compartment. But this flexor digitorum superficial is also considered as the intermediate compartment. Okay. Then extensor retinaculum is related to the lower crest. So which one is the lower crest? Lower crest. This is the lower crest. Okay, this border. Okay, rough area. So extensor retinaculum are present over there. Next slide. So posterior border, it is well demarcated only on the medial side. Okay, posterior oblique line is present on the upper half. So which one is the posterior oblique line? So you have to just see the radial tuberosity. Okay, from that you could see one line is going oblique. Okay, so this is known as posterior oblique line. Okay, next one. So this border is very important, that is intraosseous border. Right, sharpest among the other border extend from the radial tuberosity up to the ulnar notch. Okay, and pronator quadratus is attached over here. Okay, so origin and insertion of pronotal quadratus, could you remember? Origin and insertion of pronotal quadratus. So what I told, origin would be fixed, but the insertion would be movable, right? So origin would be which bone is moving over here, pronotal quadratus. During supination pronation, which bone is moving? Radius. Okay. So origin would be definitely on ulna. Okay. And insertion would be here. Okay. Insertion would be on the radius. Okay. Interosseous membrane attached to the lower tripod. Okay. Only lower tripod. Okay. So superior and inferior radioulnar joint is pivot joint. But there is another one joint that is known as medial radioulnar joint. Now tell me which type of joint it is. Superior, inferior and middle radioulnar joint. There are three joints.
Medial radioulnar joint interosseous membrane joint.
So it is a syndesmosis. Tell me another example of syndesmosis. So you have to say inferior tibiofibular joint. Okay. So example of syndesmosis. Syndesmosis means so example is inferior tibiofibular joint and middle radioulnar joint. These are the example of syndesmosis. Okay. The next one. So anterior surface. Now coming to the anterior surface. So which muscle is attached over here? Flexor pollicis longus. Flexor pollicis longus. Okay. To the upper tripod. Maximum area is occupied by flexor pollicis longus and pronator quadratus to the lower one. Okay. And nutrient canal is directed to the elbow I go. Right? To the elbow I go. That means to the knee I feel. That means nutrient artery would be going towards upward. Okay. See, it is already written. Nutrient artery. So remember this one branch. Tell me the largest nutrient artery. Which is the largest nutrient artery of our body? Ball. Posterior tibial artery. Okay, example is posterior tibial artery. So here nutrient artery is a branch of anterior interosseous artery. Okay, anterior interosseous artery. Next one. So posterior surface. So here is a flexor pollicis longus and another one is pronator quadratus. Anterior surface. Now the posterior surface is abductor pollicis longus. Okay, and extensor pollicis brevis originate from the posterior surface. Okay, so abductor and extensor. Then next one. Lateral surface, supinator, okay, pronator teres and extensor tegmental. So supinator, pronator both on the lateral side, extensor and abductor on the posterior side, and flexor and the pronator quadratus on the anterior side. So these are the relative muscle on the radius. Okay, next one. So lower end. How to know the lower end? Right? So lower end has got 5 surfaces. Anterior surface, it will articulate with the palmar radiocarpal ligament, and posterior surface we know that is a listed tubercle. Okay, and it has a groove for the extensor pollicis longus. Extensor pollicis longus. Next one. So there are other muscle also, right? Here two muscle you have to remember. One is insertion of brachioradialis. Yesterday only we have seen, right? Another one is collateral ligament. Radial collateral ligament. Okay. Next one. Same here. Adductor pollicis longus and extensor pollicis brevis and inferior surface. So here is one important thing. Which joint is making, which bone is making which joint? Last bench. Which are the bone taking part in the formation of wrist joint? So wrist joint is also known as radiocarpal joint, right? Radiocarpal joint, but there is no attachment of ulna. So radius means this lower end of radius along with scaphoid and lunate. Okay? So ulna won't be there. Okay? Next one. So see, this is the lower end. So this is the articular process that is making the wrist joint. Okay? And that side would be the styloid process. And these ulnar knot, just like radial knot, so ulnar knots will be forming what? Inferior radioulnar joint. Okay, उल्टा हो गया. Radius में क्या है? Ulnar notch. Ulna में क्या है? Radial notch. Okay, next one. So this is just you have to know. It has got one primary center which will appear at the epic. Okay, and there will be one. How many secondary center? Two. One in the upper end and another one in the lower end. Okay, next one. So this is important. So see, this is making the capitula with the radial head. So it is making the elbow joint. Okay. So while flexing, the radial deficiency would be facing upwards. Okay. This is also showing the elbow joint. So this is what is this U-shaped notch? U-shaped notch is also known as trochlear notch. Okay, so this part is the trochlea, right? And that is the olecranon process which will articulate with the olecranon fossa of the humerus. Okay. So now comes the applied anatomy. So this is important. While the head of the radius, it will dislocate anteriorly. Okay. Because the annular ligament, it is deficient anteriorly. Shoulder joint will dislocate which side? Only downwards? Anteriorly, inferiorly. Okay, but radius is, why radius dislocation is important for whom? Have you seen? Radial dislocation देखे हो किसी का? काले होए बाल? छोटो बाচ্চাদের হয়. Okay, whenever some toddler baby, okay, it is happened to them. If somebody is pulling the hand, okay, suddenly what will happen? The head of the radius will be dislocated. It will be anteriorly dislocated. Okay, so they have to very carefully handle the baby. Okay, because this is not formed. The joint is not at all formed at that moment. Okay, remember this one. And most common joint fracture in the humerus is very good. Supracondylar fracture of humerus, not the neck, not the shaft. Okay. So radius can be exposed by incision on the anterior border. Okay. By same expression with the brachioradialis. Next one. Write it down. Please have the note. Which one is the Pullis fracture? So both are Pullis and Smith fracture, both are on the distal end, right? So what would be the appearance? Okay, so first one is fall due to outstretched hand. So whatever fracture occurring in the upper lip, all are due to outstretched hand. Clavicle, right? Next one is supracondylar fracture. Then this one, lower end of radius, all will be fractured. Okay. So fracture of the radius 2 cm above the distal end with posterior displacement of the distal segment. Okay. So there will be 2 cm above the radius. Okay. And there will be posterior displacement. This displacement is important. Okay. Once there will be posterior displacement, another will be anterior displacement. Okay. So it will lead to dinner for deformity. Dinner for deformity. So Pullis is doing dinner for. Okay. So see how because it is dislocated where? Posteriorly. So that's why there will be dinner for deformity. Okay. So this is the X-ray appearance. आगे जा. Okay, Smith fracture. So that is result from fall on the dorsum or flex of the hand. Okay, flex hand means not outstretched. If somebody falls on the dorsal aspect, okay, and the hand should be on the flexed side, then only this fracture will happen. Okay, in this case, the distal end of the radius is displaced forward. Okay, so Smith में क्या हुआ? Forward हुआ. Pulis में क्या हुआ? Posteriorly dislocated हुआ. So how it will look? Next one. So see, and because it is forward, so it is looking like just reverse fork. Okay, reverse fork. It will be placed anteriorly. Okay. So this is the difference. Okay. If it is flexed towards the palm, so that is Smith fracture, and if it is going outward, so that is the Pulis fracture. Okay. Next one is, which one is the Studek osteodystrophy? Okay, what is Studek's osteodystrophy? So in this case, what is happening? Reflex to the sympathetic dystrophy occasionally follows the Pulis fracture. Okay. So there will be dystrophy means. What do you mean by dystrophy?
Dystrophy.
Atrophy means what? Atrophy means there is no use, that muscle will be atrophied, right? Hypertrophy means ki overuse, there will be enlarged. Dystrophy means some different function and there will be some different muscle, there will be accumulation. Okay, so this is known as dystrophy. So severe disuse atrophy of the bone. Okay, actually atrophy হওয়া উচিত ছিল কিন্তু instead of that এখানে dystrophy হচ্ছে, right? And temporary abnormality of sympathetic nerve causing increased vascularity. Okay, next one. So see, this is the Studek osteodystrophy. It will look like this. So what will happen? Because of diffuse atrophy, there will be increased sympathetic activity. So there will be increased blood supply. Okay. So this portion it is becoming red. Okay. So this is the example of Studek osteodystrophy. Okay. Next one. So this is the appearance in the X-ray. Okay. So this is what I am talking about in case of infant. Okay, pulled elbow. So what is pulled elbow? Sudden pull of the hand to raise the body above the ground. So you are taking the hand suddenly without any support. What will happen? It will come out. The head of the radius will come out. So it will displace the head of the radius annular ligament. I told annular ligament is deficient anteriorly, so it will come out. Okay, only seen in the small children below 5 years of age. Okay. So see, this is what happening on a happy evening. Parents are roaming the child, okay, on the park, and suddenly what is happening? There will be pulled elbow. Okay. दोनों हाथ से ऐसे करके हैमर की तरह अगर आए तो it will be come out. Okay, so it is a pulled elbow. Okay. So it could be cured. Okay. Okay, next one. This is the last one. Chopper's fracture. Okay, Chopper's fracture is fracture of the radial styloid process, typically on the generator operators. So what is happening? Have you seen the generator operator previous day? How they used to do? They will just continuously, they will force and they will just initiate, right? So at that time, what will happen? And also the driver of yesteryears. Okay, one thing is there. So for that also they have to recurrently they have to use the radius. Okay, next one. So styloid process of radius is broken. Okay, Chopper's fracture क्या होता है? There will be displacement of the styloid process of the radius. Okay, so remember the name. Pullis fracture, Smith fracture, Suday costodystomy, pulled elbow, and Chopper's fracture. Okay, so many clinical applied aspect is there. Okay, so see, this is the Chopper's fracture. Okay, so you could see that is the radius, right? Scaphoid lunate, that side it is already there is fracture, linear fracture. Okay. Okay. So that is all about the radius. Next day we will discuss about artery.
So this is the important, very important sources of one question may come 5 question, that is sources of carbon and nitrogen in from pyridine, or how pyridine is synthesized from different sources of carbon and nitrogen. So see the structure: carbon number 4, carbon number 5 and nitrogen 7. This from how you get from the glycine. Nitrogen number 3, nitrogen number 9, they will get from the glutamine. They will get from glutamine. Nitrogen 1 will get from the aspartate. And carbon number 2 and carbon number 8, they will get from tetrahydrofolic acid. They will get from methyl and formyl tetrahydrofolic acid. And carbon number 6 will get from carbon acid. This is very important structure. So synthesis of urine, right? So two processes there, or two mechanisms. One is de novo synthesis pathway, another is salvage pathway. So major pathway, out of that de novo synthesis pathway is your major pathway, and salvage pathway is the minor pathway. So in de novo, but both synthesis, both in de novo and salvage pathway. Same one, the first one step is there. Ribose 5-phosphate converted to PRP. This step will be here. Both are requirement for the both mechanism. So ribose 5-phosphate will convert into phosphoriosyl pyrophosphate. Ribose phosphate will convert into phosphoriosyl pyrophosphate. By the help of enzyme, there will be synthesis. Phosphoriosyl pyrophosphate synthesis. Now ribose 5-phosphate from where we get ribose 5-phosphate? You get very good. You get from HNO. So this step is also called as preliminary step. Preliminary step of the pyridoxine synthesis. Santiniketan told that PRP will be used for synthesis of pyridoxine, that is both for the salvage pathway and both for the de novo synthesis pathway. So after PRP, next is from PRP will be converted to phosphoribosylamine. By the help of enzyme phosphoribosyl aminotransferase. See here PRP is there. That means binding of amino group. Who will give that amino group? That amino group will be given by the aminotransferase. Okay, aminotransferase. Next, phosphoribosylamine will convert it to glycinamide ribonucleotide. By the help of enzyme, glycinamide ribonucleotide is synthesized. That means that phosphoribosylamine, so glycine, that amino acid glycine will bind with the phosphoribosylamine. As a result, glycinamide ribonucleotide will form. So that glycine given, what compound glycine is given? In pyridoxine, Glycine what giving? Carbon number 4, carbon number 5 and here N7. So now glycine, what is the role of glycine? It will give the carbon number 4, carbon number 5 and N7. Glycinamide ribonucleotide will convert into formyl glycinamide ribonucleotide by the help of enzyme transformylase. Okay, transformylase. That means here the formyl group methynyl tetrahydrofolate acid will donate the methyl group. Will donate the methyl group. What that is carbon donor. It will be carbon donor and it is converted to tetrahydrofolate acid. Next is the formyl glycinamide ribonucleotide will converted to formyl glycinamide ribonucleotide by the help of enzyme amylotransferase. That is formyl glycinamide ribonucleotide. So here amino group that nitrogen is there. That this nitrogen who will donor? Yes, that will be donated by the glutamine. Glutamine will donate this nitrogen. Now formyl glycinamide ribonucleotide will convert it to amino imidazole ribonucleotide by the help of enzyme cyclase. That means, so this is the step was there. Now after next step is here, that cycle will be completed. That means, see here, cyclization. Next, amino imidazole ribonucleotide will convert into amino carboxy amino imidazole ribonucleotide. Who will give that by the help of enzyme carboxylase. That means this is an example of which kind of reaction this is? Carboxylation reaction. That is binding of carbon dioxide or attachment of carbon dioxide. Next, amino carboxy amino imidazole ribonucleotide will convert into succinyl amino imidazole carboxamide ribonucleotide. Here binding of aspartic acid. Listen, if aspartate or aspartic acid is binding here, next step what will be removal? Attachment of aspartate here. Next step what will be removed? Fumarate will be removed. Okay. So, by the help of synthetic enzyme, it will convert into succinyl amino imidazole carboxamide ribonucleotide. See here, fumarate acid removed. Right. Last step. Aspartic acid binding was there. Aspartic acid or aspartate. Here, fumarate removed. So next, by lyase enzyme, succinyl amino imidazole carboxamide ribonucleotide will convert into amino imidazole carboxamide ribonucleotide. Next, by transformylase enzyme, formyl amino imidazole carboxamide ribonucleotide will form here. What is this? One carbon. But that carbon will be donated by this formyl group. Formyl tetrahydrofolate acid, that formyl group will be transferred here. Now, from formyl amino imidazole carboxamide ribonucleotide, IFP will be synthesized. That is, iodine monophosphate IFP will be synthesized by IFP synthesis. Is it by adding one more water or by dehydration? Okay. Now we got the IFP. Started from here. You started from phosphorus 5%. So DRPP, from DRPP you get the IFP. Okay, once you get IFP, and IFP to AFP, other things can be AFP, GFP, other things will be converted. This is the first steps. This is the IMP. Then IMP can be converted to AMP. That is adenosine monophosphate by the help of enzyme synthetize adenyl succinase. Two step is the protein, one step written. Here aspartic acid or aspartic is there. Then by donating the amino group, it will phenol will be removed. Yeah. Then IMP can be converted to GMP. First IMP will be converted to, that is XMP, xanthosine monophosphate. Xanthosine monophosphate by the help of enzyme dehydrogenase enzyme, and as it is dehydrogenase it is the aridity dependent. Then from xanthosine monophosphate GMP can be synthesized. Guanosine monophosphate can be synthesized. Once GMP synthesized means from GMP to GDP and GTP. So xanthosine monophosphate by the help of enzyme amino transferase GMP can be synthesized. Here see, this amino group is there by the who will give that, who will do not of that amino group? Glutamine. Yes. And who will then help for the transfer of amino group? Amino transferase. That is here major pathway, minor pathway, that is salvage pathway. Salvage pathway mostly occurs in the brain where deoxygenasis pathway will be not operated. Adenine can be converted to AMP by the help of enzyme adenine phosphoriboside transferase. The two steps is very important step. Salvage pathway here short notes, I got to say. So adenine can be converted to AMP. Here ARP will be adenine binding with ARP, as a result AMP can be formed by the help of enzyme adenine phosphoriboside transferase. And guanine converted to GMP by the help of enzyme HGPRT, that is hypoxanthine guanine phosphoriboside transferase. Okay, and due to deficiency of this HGPRT, what disease occurs? That is Lesch syndrome. These are the regulations, inhibitors of purine synthesis. Here short notes. Inhibitors of purine synthesis. They act as analogs. Analogs means structural should be structure, similar structure. They act as a competing inhibitor of the naturally occurring nucleotides. They are utilized to synthesize DNA. Such DNA becomes functionally inactive. Understand? So that compound will bind, and as a result, new DNA will be synthesized. That new DNA will be inactive. So as due to that what will happen? Cell division will be stopped. So what is the utility of that analogs? Utility as a anti-cancer drugs. We are utilizing anti-cancer drugs. That is the important. That is same structural or analogs we are using in purine synthesis inhibitors. These are the examples: 6-mercaptopurine, methotrexate, azaguanine, hydroguanine. All these things are the purine synthesis inhibitors. 6-mercaptopurine, what is the role? It will inhibit the IMP to GMP and AMP. So IMP cannot be converted to GMP and AMP. Methotrexate, this is the folate antagonist. That means that one carbon group will be not available. Azacylin also, it will be glutamine antagonist. This is liquid preparation already discussed. So IMP converted to xanthosine monophosphate and xanthosine to GMP guanosine monophosphate. One side diphosphate, one side triphosphate. One side triphosphate. That GTP will give positive feedback to the IMP. Positive feedback to the IMP. As a result, IMP to ATP can be synthesized. ATP can be synthesized. And ATP will give positive feedback to xanthosine monophosphate. As a result, GTP can be synthesized. But suppose the level of GTP will be more. What will happen? That GMP at that time GM will give negative feedback to the IMP. Negative feedback to the IMP. As a result, IMP will be IMP to xanthosine monophosphate or GTP synthesis will be stopped. Okay, like that. Here ATP will give positive feedback to formation of GTP. If more and more ATP will be accumulated, what will happen? What will happen? That AMP will give negative feedback to the IMP. As a result, IMP to ATP synthesis will be stopped. Okay, these are the feedback. This is very important here. Degradation of pure nucleotide or synthesis of uric acid. Uric acid synthesis. So adenosine monophosphate, all of you should listen carefully. Adenosine monophosphate will convert it to adenosine monophosphate by the help of enzyme B aminase. AMP adenosine monophosphate B aminase. So what is the role of B aminase? B aminase it will remove the amino group from AMP adenosine monophosphate. Okay. Then after removal of amino group, the new compound that is adenosine monophosphate will be formed. Okay. Then IMP converted to iodine by the help of enzyme phosphomonoesterase enzyme. That means addition of water or hydrolysis occurs. Okay. And that phosphate group will be inorganic phosphate will be removed. Now iodine will be synthesized. Then iodine can be converted to hypoxanthine by the help of enzyme purine nucleoside phosphorylase. So ribose 1-phosphate will be removed from iodine. Okay, ribose 1-phosphate will be removed from the iodine. Then hypoxanthine, this two step is very important. Hypoxanthine will convert it to xanthine and xanthine converted to uric acid. See, these two reactions are same enzyme, that is xanthine oxidase. Okay. So hypoxanthine converted to xanthine and xanthine converted to uric acid by the same enzyme, that is xanthine oxidase. Okay. In gout, what will happen? Gout, the level of uric acid will be high or increased. So what will happen? That time what drugs we are giving? Allopurinol. How that allopurinol works? That allopurinol, here this word, allopurinol will be inhibit this xanthine oxidase enzyme. So as a result, alloxanthine will form. And easily it will be excreted. Okay. Then that xanthine oxidase will more potent inhibitor of that xanthine oxidase. Okay. So uric acid will be synthesis will be stopped. Yes, it is competitive. Then this xanthine oxidase it is a molybdenum and nephrine containing enzyme. Viral question will ask molybdenum containing enzyme, that is xanthine oxidase. So again adenosine will converted to iodine by the help of enzyme adenosine deaminase. That means removal of amino group from adenosine. Then once you got that iodine, then it can be converted to xanthine, hypoxanthine, xanthine and uric acid. Guanosine can be converted to xanthosine by one enzyme. That means removal of amino group, and that xanthosine will be converted to direct xanthine by the help of enzyme purine nucleoside phosphorylase. Here removal of ribose 1-phosphate. ribose 1-phosphate from xanthosine. And same guano side, both reactions see carefully. Same guano side here xanthosine converted, but same guano side can be converted to guanine. By the help of enzyme, we will nucleoside phosphorylase. Ribose 1-phosphate will be removed from the guano side. So guanine, then guanine by the help of enzyme guanase, amide group will be removed and it will form. It can synthesize xanthine, and xanthine can be synthesized uric acid. Anybody can tell this is what is the chemical structure of this uric acid? Chemical name? What is this group? This 3 oxygen is there. 2,6,8 triiosopurine. Understood this? Any doubt here? Because this is very, very important. But normal level of uric acid, that will be 2 to 5 or 2 to 6 mg per ml in female and 3 to 7 mg per ml in male. What is hyperuricemia? Hyperuricemia here. 10 mark question. So serum uric acid concentration will be increased more than 6 mg per ml or 7 mg per ml. That you can tell that is hyperuricemia. Gout, very important. It is that is same like hyperuricemia. It is due to accumulation of urate crystal. What type of urate crystal that is? Sodium urate crystals. Sodium urate crystals in the synovial fluid. So due to that deposition of sodium urate crystals, that inflammation occurs and that it will cause the acute arthritis.
Sir, hyperuricemia feeling of system.
Same.
Active
All these things are under hyperuricemia. Yes. So uric acid is deposited to cause a stuffy and it is mostly seen in the distal joints of food. It may form calculi or stone formation, and what is the cause? That is due to that abnormal fiber-hydroxyl amide transferase and glucosine phosphate deficiency. Glucosine phosphate deficiency, what happens? It is a, if this deficiency is there, so glucosine phosphate can be converted to glucose. As a result, it will go for which pathway? HMP pentose phosphate shunt. HMP pathway. Then once it will go HMP pathway, what will happen? More and more ribose 5-phosphate will synthesize. Most ribose 5-phosphate will synthesize, then it will go conversion of PRP. More PRP converted, it will go for synthesis of uric acid. Okay. That means there will more and more PRP accumulate, it will go for synthesis of pyrinyl nucleotide. If it is more synthesized, then it will go for catabolism.
Basic metabolism.
Yes. Secondary hyperuricemia or secondary gout, that will be due to growing malignant tissue like leukemia, lymphoma, and polycythemia vera. That is due to increased turnover of nucleic acid. Mostly it will attack the first metatarsophalangeal joint. These are the drugs. Okay. I told that allopurinol one will give. What will happen? It will block the formation of uric acid. It will inhibit the which enzyme? Xanthine oxidase. And probenecid also can be given that it will increase the excretion of uric acid in the urine. Non-steroidal anti-inflammatory drugs also can utilize. Colchicine, corticosteroid, logistics, they will reduce the inflammation. So first will reduce your urine intake diet, then reduce the urine production by allopurinol. Okay. Now we'll start. How many members are there? Now read 10 minutes this slide. Okay. All of you, anybody do book? Books like you book are book. What I do? We'll start with this session. 2 questions I will give you. Okay. This is one. Periodic degradation. Okay. Periodic write down the question. Question write down. Question 1. Question number 1. Describe about degradation of pyrinicotide. Okay, this one. And next question. Question number 2. Write down the source of carbon and nitrogen. The source of carbon and nitrogen in a urine ring. In a urine ring okay, these 2 questions, group A, group B. These 2 questions, all of you practice it. This one question and question number 1, question number 2. Both questions, all of you practice it first. I am giving 15 minutes time. Okay. 15 to 20 minutes time to take. Then I will tell you question group A. You will come here and you will describe. Okay. Then other group what will do? They will rectify your mistake. Okay. Same thing also your group. Okay. Another question I will give you. You will come here. You will describe and group A or group B, they will be rectify your mistakes. Okay, now start the time. I am giving 15 minutes. So now group A, they will start regarding the sources of carbon and sources of nitrogen in urine ring. You will check that structure.
Here is the structure of purine ring.
Now, here. Good. Now here you correct it. Is it correct?
So, niacin coming from C457 and they are written it C6. That's
So
the
numbering is a bit wrong, I think.
Yes, C4, C5, and 7. That C5 is the correct.
Yeah,
Yes, 4, 5 yes. Yes. C4, C5, and 7. Now this correct. Now it is okay?
So here is a purine ring structure. So as we can see that purine rings have different sources. Here purine ring source is synthesized from different small components. Small components are also called their sources. As we can see, there are nitrogen 1 is its source is amino group of aspartate. Nitrogen here, nitrogen is source is amino group of aspartate, and carbon 2 is forming from formyl tetrahydroformic acid.
Folic acid.
Folic acid.
Formic acid or folic acid?
Folic
acid. Yes.
That's my mistake.
Yes.
Tetrahydrofolic acid, and here you can see in 3 and in 9 are forming from amide of glutamate, amide of glutamate, and C4, C5, and in 7 are forming from glycine. Its source is glycine, and C6 is from respiratory CO2. As we breathe the respiratory CO2, C6, and C8 is from methyl tetrahydrofluoric acid.
Very good. Is it okay? Or any questions you want? Any doubt is there? Or any mistake is there? Is it okay? Okay, out of 10 marks, how much you want to give? Your group?
7.
27. Okay. The little bit mistake was there, just C4, C5 mistake was there. Okay, for that you are giving 7. Okay. Okay. Give your plus.
Thank you, sir.
The degradation of purity, right? In the structure, if any mistake is there, you can come and you can correct it. Understand? From here, bro, is it okay?
Yes, sir, okay, but they haven't written the coordinate exchange possibility.
Okay, you can come. Correct it. What is their mistake is there? Correct it.
Sir, they are correct.
Mistake টা কোথায় আছে তোমরা দুজন এসে কারেক্ট করো।
Yes, sir.
Now it is okay?
Who's going to give us some questions?
Okay, come, correct it. Mobile kit there. Mobile kit there. H2 O.
H2 plus 1.
Now H2O return. Then what is the enzyme? Here, one is converted to xanthine, and xanthine converted to xanthine. What is that enzyme? That enzyme is not there.
Place inside.
Eh? Come and write. This one, last one, what is the enzyme? This one.
This one.
No, last one, that one is this one.
One is.
One is, yes. Now it is okay? You are good?
Yes, sir. Yes.
Huh? Everything is correct?
Yes.
Let's grab it now. Take this. Take this name, please. Let's grab one, let's grab.
This is adenosine monophosphate, which is deaminated to form hydroxyl monophosphate, and then phosphomonoesterase, which is removing the phosphate and forming the inosine. Inosine, after that, by the enzyme purine nucleoside phosphorylase, which is forming the ribose 1-phosphate, forming hypoxanthine. Hypoxanthine then further by the action of xanthine oxidase forming xanthine. Xanthine by action of the same enzyme xanthine oxidase forming uric acid, and with an alternate pathway from adenosine it is forming inosine by adenosine deaminase enzyme. It can be on inosine. This pathway can also go on by guanosine. Guanosine by action of 1S forming xanthosine, which forming xanthine and further uric acid. Guanosine by the action of PNP forming guanine, which by action of guanase forming xanthine and that further forming uric acid.
Is it okay? How much? Out of 10, how much will you give?
6.
Why?
Sir, there are some mistakes.
There are some mistakes. Okay. Okay. Thank you. Give a big round of applause.